Welcome to This Week in Pulmonary and Critical Care Medicine. I'm your host, Aladdin Sagar. This is your weekly, evidence-based update designed for busy clinicians who want to stay current without getting lost in the noise. This week's episode brings together 3 studies that at first glance seem quite different, but are linked by a common clinical tension: how far we should go in intervening when the signal is promising, but uncertainty remains. We'll start with symptom control in a population where quality of life is often overlooked, move into infection prevention after cardiac arrest where unintended consequences matter, and finish with a practical, physiology-driven walkthrough of managing one of the most complex pulmonary vascular diseases we see in practice. As always, the focus here is clinical context, real numbers, and what these papers actually mean at the bedside. Let's start with cough in idiopathic pulmonary fibrosis.
Chronic cough in idiopathic pulmonary fibrosis is one of those symptoms that clinicians acknowledge but often feel powerless to treat. It affects the majority of patients, substantially impairs quality of life, and persists even when disease-modifying antifibrotic therapy is optimized. That gap between physiologic disease control and symptom burden is where this first study sits. Published in JAMA this month, the CORAL trial evaluated extended-release Nalbuphine for IPF-associated chronic cough. This was a Phase 2b randomized double-blind placebo-controlled trial conducted across 52 sites in 10 countries. Investigators enrolled patients with confirmed IPF who had chronic cough for at least 8 weeks and a cough severity numerical rating score of 4 or higher. A total of 223 patients were screened, and 165 were randomized in a 1-to-1 fashion to Nalbuphine extended release at doses of 27 mg, 54 mg, or 108 mg twice daily, or placebo for 6 weeks. 160 patients were included in the primary analysis. The median age was 71 years, about 29% were women, and baseline objective cough frequency was high, averaging 28.3 coughs per hour. The primary endpoint was the relative change from baseline in 24-hour cough frequency at week 6, measured objectively using a digital cough monitor. Compared with placebo, all 3 Nalbuphine doses reduced cough frequency substantially. The 27 mg dose produced a 47.9% reduction, the 54 mg dose a 53.4% reduction, and the 108 mg dose a 60.2% reduction. By contrast, placebo resulted in only a 16.9% reduction. These differences were statistically significant. In absolute terms, cough frequency fell from 24.6 to 11.9 coughs per hour in the 27 mg group, from 28.0 to 14.9 in the 54 mg group, and from 31.5 to 11.9 in the 108 mg group. That magnitude of effect is not trivial, particularly in a symptom that patients often describe as relentless. Patient-reported outcomes told a more nuanced story. Using the Evaluating Respiratory Symptoms in IPF cough subscale, only the 2 higher doses showed statistically significant improvement. The 54 mg and 108 mg groups both demonstrated approximately 40% relative reductions in patient-reported cough frequency, while the 27 mg dose did not reach statistical significance. Mechanistically, Nalbuphine is a kappa opioid receptor agonist and mu opioid receptor antagonist, which distinguishes it from traditional opioids used for cough. The theoretical advantage is reduced risk of respiratory depression and dependency, though this trial was not powered to fully assess long-term safety. So how should we interpret this? The signal for objective cough reduction is strong and dose-dependent. The disconnect between objective and subjective outcomes at lower doses suggests that cough frequency alone may not fully capture patient experience, or that a threshold effect exists for perceptible benefit. Importantly, this was a short 6-week study. We still lack data on durability, functional outcomes, and longer-term adverse effects. This is a promising step towards symptom-directed therapy in IPF, but it is not yet a green light for widespread adoption. If the first study asks whether treating symptoms aggressively can improve quality of life, this second paper asks a different question: whether intervening early can prevent harm without creating new problems. Published in Chest this month, the PROTECT trial examined prophylactic ceftriaxone in comatose survivors of out-of-hospital cardiac arrest treated with targeted temperature management. Early onset pneumonia is common in this population, occurring in up to 2/3 of patients, but routine antibiotic prophylaxis has remained controversial due to concerns about resistance and unclear effects on hard outcomes. This was a single-center, randomized, placebo-controlled pilot trial. Of 411 patients screened, only 53 were randomized, reflecting both strict eligibility criteria and real-world enrollment challenges. After one withdrawal, 52 patients remained in the final analysis, with 26 patients assigned to ceftriaxone and 26 to placebo. Participants received ceftriaxone 2 grams intravenously every 12 hours for 3 days, or matching placebo. The primary outcome was adjudicated early onset pneumonia within 4 days of intubation. Pneumonia diagnosis was performed by blinded pulmonologists using predefined criteria, which is a notable strength in a notoriously subjective outcome. Early onset pneumonia occurred in 38% of patients receiving ceftriaxone, compared with 69% in the placebo group. This corresponded to a risk ratio of 0.57, with a 95% confidence interval of 0.21 to 1.001 and a p-value of 0.05. Statistically, this sits right on the margin of significance. Beyond pneumonia rates, the study examined antibiotic exposure and resistance. Open-label antibiotics were administered to 54% of patients in the ceftriaxone group versus 85% in the placebo group, with a risk ratio of 0.64. Most of these antibiotics were broad-spectrum agents. Importantly, metagenomic analysis of rectal swabs showed that patients receiving ceftriaxone acquired significantly fewer antibiotic resistance genes, with an incidence risk ratio of 0.30 after adjustment for baseline differences. No serious adverse drug effects were reported in either group. However, the trial was underpowered for mortality, neurologic outcomes, ICU length of stay, or ventilator-free days, and enrollment was stopped early due to slow recruitment during the pandemic. So what do we do with this? The reduction in pneumonia and downstream antibiotic exposure is clinically appealing, especially in an era where stewardship matters. But this remains a pilot study with wide confidence intervals and potential baseline imbalances. The finding of reduced resistance gene acquisition is intriguing, but it should be viewed as hypothesis-generating rather than definitive. This trial does not justify routine prophylactic antibiotics after cardiac arrest, but it does challenge the assumption that prophylaxis inevitably worsens resistance. Chronic thromboembolic pulmonary hypertension is a disease where outcomes depend less on a single intervention and more on timing, physiology, and system-level coordination. Published in Chest in January 2026, this How I Do It review walks through the perioperative management of patients undergoing pulmonary thromboendarterectomy, offering insight into how experienced centers approach this complex population. CTEPH begins with unresolved thromboemboli that become fibrotic obstructions, increasing pulmonary vascular resistance and imposing a progressive pressure load on the right ventricle. What is often underappreciated is that macrovascular obstruction is only part of the story. A parallel microvasculopathy develops over time, which explains why delayed diagnosis leads to worse outcomes even when surgery is technically successful. Pulmonary thromboendarterectomy is the treatment of choice for operable disease, but operability itself is not binary. It depends on clot distribution, surgical expertise, and patient physiology. The authors emphasize that multidisciplinary evaluation is essential, not optional. Decisions about surgery, balloon pulmonary angioplasty, or medical therapy should never occur in isolation. Preoperatively, anticoagulation is foundational. Most patients can be managed with vitamin K antagonists or direct oral anticoagulants,
but antiphospholipid syndrome remains a clear exception, where warfarin is preferred. Importantly, the authors caution against routine preoperative pulmonary hypertension therapy as a bridge to surgery. There is no evidence that this improves outcomes, and it may delay definitive treatment. The immediate postoperative period is where physiology matters most. After thromboendarterectomy, pulmonary vascular resistance can fall dramatically, but the right ventricle does not instantly remodel. The result is a heart that is suddenly underloaded but still stiff and dysfunctional. Inotropic support is often necessary, with dopamine commonly used at low doses to support cardiac output while promoting diuresis. Ventilator management is deliberately counterintuitive for clinicians used to lung protective strategies. Because perfusion is preferentially redirected to previously underventilated lung regions, atelectasis can produce profound hypoxemia. Tidal volumes of 8 to 10 milliliters per kilogram of ideal body weight are routinely used to maintain alveolar recruitment and minimize ventilation-perfusion mismatch. Anticoagulation is restarted early, typically on the night of surgery once mediastinal drainage is minimal. Boluses are avoided, and vigilance for heparin-induced thrombocytopenia is critical, particularly in patients with prior exposure. Residual pulmonary hypertension after surgery does not necessarily represent failure. It may reflect distal disease or microvasculopathy, and these patients may benefit from targeted medical therapy or balloon pulmonary angioplasty after recovery. This review is a reminder that excellence in pulmonary vascular care is not about memorizing protocols. It is about understanding how anatomy, hemodynamics, and time interact, and adjusting management accordingly. This week's studies highlight 3 different ways we intervene in pulmonary and critical care medicine: treating symptoms directly, preventing complications early, and managing complex physiology with experience and precision. Each offers promise, but each also demands restraint. As always, these data should inform practice, not dictate it. Larger trials, longer follow-up, and continued physiologic understanding are still needed. If you found this episode useful, consider subscribing so you don't miss future updates. Thanks for listening, and I'll see you next week.